Let me take a moment to talk about hypertensive emergencies. These are situations where the systolic blood pressure exceeds 200 or the diastolic pressure climbs beyond 130, often accompanied by optic disc edema or perioperative hypertension. They're not rare, frequently stemming from either noncompliance with medication or refractory essential hypertension. Historically, the term malignant hypertension was used to describe a condition involving encephalopathy, nephropathy, and papilledema. The most common cause? Uncontrolled essential hypertension. Other culprits include renal vascular hypertension, often identified by a sudden spike in creatinine levels when using ACE inhibitors or ARBs, and conditions like preeclampsia, eclampsia, and HELLP syndrome. Hypertensive emergencies can also arise post-head injury or stroke due to aortic coarctation or from substance use, cocaine being a notable example where beta blockers should be avoided. Medication issues like acute withdrawal of antihypertensives, NSAIDs, or simple noncompliance can also trigger these crises. The workup is critical. It includes basic tests like CBC, electrolytes, BUN, creatinine, and urinalysis. Depending on the symptoms, you might also need ECG, troponins, a chest X-ray, or specialized tests like a toxicology screen, pheochromocytoma workup, 24-hour urine metanephrines, evaluations for eclampsia, or a CT head scan. Management revolves around addressing the underlying cause. For urgency, oral medications suffice, and the blood pressure should be gradually reduced over a few days. This can often be managed in the ward or outpatient settings. However, emergencies demand intravenous medications to lower blood pressure within an hour, typically requiring CCU or ICU admission. It's crucial not to aim for a normal blood pressure too quickly. Instead, focus on reducing the mean arterial pressure. The goal is usually to bring the diastolic pressure below 110 within 6 hours. In certain cases, such as acute ischemic stroke without TPA therapy, permissive hypertension might be the strategy for the first 24 hours, treating only if systolic pressure exceeds 220 or diastolic pressure exceeds 120. Special cases like pheochromocytoma, Cushing syndrome, or primary hyperaldosteronism also require tailored approaches. Hypertensive emergencies demand swift, focused intervention and a clear understanding of the underlying cause to prevent life-threatening complications.